Good afternoon, everyone. Thank you for joining us today for our presentation, Advancing an Inclusive Anti-Racist Culture in Nursing, Tufts Medical Center and Tufts Children's Hospital. It is with great pleasure that I introduce the panel and the moderator today. But before I start, I would like to just take a moment and introduce myself. My name is Judy Cullinane. I'm the Associate Chief Nursing Officer for the Robert and David J. Center for Nursing Excellence. And today we will be sharing this wonderful today we will be sharing this wonderful presentation with you. And we hope that you will enjoy this great work these nurses are doing and paving the way for better healthcare through advocacy and actual transformational leadership. I'd like to begin by introducing Dr. Rosa Colon-Calaco, who is our VP and Chief Diversity, Equity, and Inclusion Officer at the Welfare System level. Rosa comes with an extensive amount of experience in the field, and she works closely with Tufts Medical Center, as well as our partner organization, bringing a strategic direction to this important work. She received her PhD in Organizational Development and Change at Benedictine University, an MBA from Henley Business School, and a post-marketing diploma from the Charter Institute of Marketing in London. Our panelists, and I'll begin with the nurses, are Cynthia Orifo. She is a graduate of Northeastern University. She has her BSN from the university, and she's also a second year student, at the university for her PhD. Mary McIsaac is also a nurse, and she has her BSN from Northeastern University. Mary also has a bachelor's in allied health from the University of Connecticut. Tyra Dukes is actually from the Tufts Children's Hospital Pediatric Intensive Care. And Tyra actually began at Tufts Medical Center as a clinical technician, clinical care technician, and she is now a staff nurse in the pediatric ICU. And Tyra is also a graduate of Northeastern University, and in the fall will be beginning her work in her master's program to become a nurse practitioner. Pam Duggan is a long-term nurse here at Tufts Medical Center of 24 years. Pam has her master's and certifications both in critical care nursing and in neuroscience nursing. She is currently a clinical instructor in the peri-anesthesia area for the peri-holding area and the PACU area. And with that, I would like to pass on to Rosa Colon, our moderator for today.
Good afternoon, everybody. This is Rosa. I'm very honored to be here with all of you and our great nursing leaders at Welfare and Tufts Medical Center. What I would like to do as a moderator is to really frame our conversation today. We are really committed to build a culture of inclusion, but also to care for each other, care for our providers, care for our people, and also our communities we serve. And also we are looking constantly to see how can we eliminate structural racism so we can achieve equity for our people from the racial equity perspective, and also healthcare disparities. So this model, which I'm introducing to you, have three elements. So you can see we have a systemic approach to this work, where workforce is critical from demographic, from opportunities to workplace, from practices that we're going to share today, and also policies that we're changing to make sure that all policies that may have structural racism embedded into them for a very long time can be updated. And also we need to learn how to do the work of D&I. As we know, there's a lot of pieces from unconscious bias, from how can we do healthcare disparities. So we are very committed to have that talent destination where we can work and learn together so we can really constantly improve our culture to be inclusive for all, including our communities that we serve. That during this pandemic, it has highlighted the need to work together to not only eradicate COVID, but also have vulnerable populations vaccinated. So you can see the different puzzles of our strategy, and you will see examples of our strategies through our conversations today. and pass it to the next speaker.
Thank you so much, Rosa. So on behalf of this kind of nursing diversity, equity, and inclusion work group, we just want to first give a big thank you to Tufts Medical Center, Tufts Children's Hospital, and the Boston Globe for allowing us this forum to be able to reach people with this very important message today. So thank you, and thank you to the participants for joining. We wanted to start the conversation off just talking about the nursing profession in general. 2020 was the year of the nurse, and what a year 2020 was. We saw nurses sacrifice family and their livelihoods to be at the bedside, taking care of patients, educating patients. Nurses really went all out this year, 2020, amidst the COVID pandemic. So some of the key pieces of our presentation that we wanted to focus on is really that advocacy piece of nursing and the profession of nursing. And so nursing as a whole, or rather advocacy, is a pillar of nursing as a whole. It's in our code of ethics. It's something we do in and out on a daily basis. But nursing is also a partner within the organization to help the livelihoods of patients, of other staff members, and of the greater society as a whole. And then nursing also should be really a representative of the greater society and the patients we take care of. So these are kind of the big key points that we're really trying to focus on with this presentation. Nursing has and will continue to be a pillar of advocacy, not only for our patients, like I said, but also hopefully for the greater society. As nurses, we have many roles. We spend the most time with our patients compared to any other sector any other group in the healthcare sector. We talk to them, we console them, we counsel them, we listen to them, encourage them, and we strive to always carry a message of inclusion. And this doesn't only equate to bedside nursing. The scope of nursing is so large and extended, and the impact we can have. This is, bedside nurses, nurses in research, nurse leaders, nurses out in the community doing public health. The nursing is so dynamic that just with one degree, there's endless doors of opportunity open so that we can care for others and affect change throughout our world. Here at Tufts, we have about 1,500 nurses from speaking clinically at the bedside up through advanced practice nurses, up through nurse leaders, you name it. We're a very large group. And we really want to highlight that this organization is open to learning the viewpoints of other people and the livelihoods of other people different than themselves, as well as committed to advocating and changing the culture here into something that we envision it to be, and to be the best that we can be. So with that, I will pass it back off to Rosa so she can introduce the next speaker.
Yeah, I think I'm introducing Cynthia.
Hi, good morning, everyone, or good afternoon. I just wanted to touch on a bit of the history of racism in U.S. healthcare. The longstanding history of racism in U.S. healthcare has generally been underexplored, and this is due in part to the differences in the treatment and then the outcomes between racial groups. They've been attributed solely to science. The foundations of U.S. medicine placed non-whites in a position of inferiority for a very long time. Citing a debunked science called phrenology, which actually used the divots in enslaved human skulls to justify and determine that they had overall lower levels of aptitude and mental abilities than their white counterparts. This racist medical theory that justified this notion of inferiority of enslaved Black Americans was similarly seen with our founding mother of modern nursing, Florence Nightingale. She played an active role in calling for the genocide of Indigenous men and women throughout Great Britain and under British imperialism, and believed that non-whites were not worthy of the same rights to receive or provide care as whites at the same time. And while we have non-white nurses of the same era, like Mary Seacole, who's a Jamaican American nurse who challenged the racial ideologies in nursing to provide exceptional care to marginalized groups, fighting to practice alongside white nurses, they've often been excluded from nursing history.
So as we can see, as far back as 1896, a landmark decision, Plessy versus Ferguson, the Supreme Court ruled that separate but equal was actually the law of the land. This established the African American population was to be served separately from whites as long as the healthcare facilities were deemed comparable in quality. This essentially enshrined the constitutionality of racial segregation. After this restrictive legislation, separate public accommodations based on race became the legal norm in America, having some of the longest lasting effects than any other civil rights decision in American history. It was only recently overturned in 1954, almost half a century later. This mentality instituted the era of human subject trials. The Tuskegee syphilis experiments were some of the worst ethically abusive studies in our country's history. They were conducted in the 30s by the United States Public Health Service and the CDC. The purpose of the studies was to, quote, observe the natural history of untreated syphilis in Black populations. The men in the study were told that they were receiving free health care from the government. They were just given disguised placebos and ineffective procedures and treatment. Despite penicillin coming in the market in 1947, the men in the study were never given the standard treatment for syphilis. By the time there was a leak to the press almost 40 years later in 1972, 28 patients had directly died from syphilis, 100 died of syphilis complications, 40 of the patients' wives were infected with syphilis, and 19 children were born with congenital syphilis. An additional example of the racist application of law occurred with the life of Henrietta Lacks. Henrietta was an African-American woman who died of an aggressive form of cervical cancer. Her cells were then taken without her knowledge or consent, and once they were found to have the extraordinary ability to survive and reproduce, they would be passed on and eventually would go on to become one of the most important cell lines in American history. Following the Tuskegee syphilis experiments is the exploitation and abuse of low-income African-American women. In the 1970s, a device called the supercoil device came on market as birth control. It caused uncontrollable bleeding, abdominal pain, and in some cases, hysterectomies. Approximately 20 young, mostly poor African-American women suffered unintentional abortions from this device. Black women also became patients who suffered unnecessary, unplanned hysterectomies at the hands of medical students at many teaching hospitals across the country. These hysterectomies were solely for the purpose of medical students' own surgical practice. African-American women in sexual reproductive health would be capitalized on for many years, almost becoming routine medical care being perpetrated in our own healthcare system. The instances of abuse are numerous. African-American women are more likely than their white counterparts to be advised on restricting pregnancies and are more likely to experience resistance when seeking family planning services.
Moving forward on the timeline, in 1951, the American Nurses Association merged with the National Association of Colored Nursing Graduates to become a racially integrated organization. 70 years ago, professional nurses were still dealing with outward systemic racism of being seen as other. The American Nurses Association is just one of many professional healthcare organizations that had actively reinforced or passively accepted racial inequalities and exclusion of clinicians of color for over 100 years. Because of this, historically, the minute amount of non-white clinicians who could get accepted into schools of health and of those who graduated could often only find employment at lower quality hospitals. As for patients of color, the disparities aren't getting resolved quickly enough. A great example in the state of New York, the last 30 years has been a series of poor healthcare policy making that directly affects patients of color, and specifically those who are low income. In 1997, New York dismantled its process of fairly setting hospital reimbursement rates, leading more powerful academic medical centers in a better position to ask for higher reimbursement rates than its smaller safety net counterparts. At the same time, New York has decided to redirect the indignant care pool funds, which historically have been to stabilize those safety net hospitals that serve low-income communities. This has led to the closure of 43 hospitals statewide, resulting in the loss of 21,000 beds. These closures mostly occurred in poor neighborhoods where non-white people tend to live. Furthermore, the COVID-19 pandemic has highlighted the racial disparities in healthcare even further, with non-white patients dying at a proportionally higher rate than their white counterparts, and also with their hesitancy to obtain the COVID vaccine. to obtain the COVID vaccine based on the history of this nation. And with some of these examples that you've heard from my colleagues, the infamous legacy of racism in American healthcare has aided in the creation and the maintenance of these barriers, both within the system and for patients.
So an important question that we have to ask ourselves as nurses and then just general individuals of society is, where are we now? The history that we talked about in the last slide plays out today, and it doesn't escape us, whether it be in the care of patients, in the workforce, or in society in general. And there are very many different lived experiences involving racism in patient care. For example, in general and in nursing, we've seen or heard of instances where white patients make racist comments towards non-white clinicians, even refusing to receive any care provided by them to this day. We see refusal of nurses and doctors to explain procedures to those who hold English as a second language because they may not understand anyways. We see discrimination in the care of marginalized racial groups. An example of this being seen in a Black patient in sickle cell crisis. And if anyone knows, sickle cell crisis is it's a very painful experience when a individual with sickle cell enters that crisis state. They're just being written off as theatrical or dramatic, melodramatic, rather than having their pain control escalated. In a 2016 study published by the Proceedings of the National Academies of Science found that half of white medical trainees, these are medical students, hold the belief that Black people have thicker skin or less sensitive nerve endings than white people. A publisher in 2019 pulled a $235 nursing textbook from the market because it encouraged student nurses to respond to patients' pain based on that patient's racial, ethnic, or religious identity. And as we transition into the workforce, I can think of an incident where a Black nurse in proper attire, scrubs, and a badge was confused as a family member by the physician who had entered the room to come consult with the patient and with the patient's nurse. Because of the racial concordance of that patient and that nurse, they were both Black. That interprofessional dynamic that we see with nurses and physicians is also seen where nurses are the perpetrators of racism or discrimination or microaggressions towards other members of the care team. And unfortunately, support staff were essential to patient care and overall have a different racial makeup than nurses, have been subjugated to microaggressions and exclusion by nurses. And it's essentially unfortunate that other members of our care team do experience that. Non-white nurses have also experienced similar ostracization at the hands of white nurses. The racism in nursing and in healthcare in general is unique in the fact that it's not always as overt as other fields of work. However, the effect of this dichotomous presence of racism is detrimental to non-white patients, of course, but it's also detrimental to the nursing workforce and the entire healthcare system. Because of this, nurses and all other healthcare professionals must adopt a culture of anti-racism individually and systemically. So now, what is anti-racism? That is something that we're calling for our own institution to adopt a culture of, and for us to be anti-racist in our own individual capacities, not only as nurses, but as individuals of society. And anti-racism is becoming aware of and combating the ways in which racism affects the lived experiences of people of color, is systemic and embedded in foundational aspects of society and manifests in individual attitudes, policies, and practices within the institutions.
So now that we know what it means to be anti-racist, how do we get there is usually the next question that a lot of people ask. And so becoming anti-racist as an individual, an industry, and as a society is not going to be an easy feat. It's something that will require constant work, and the path of the journey is definitely not a linear one. So one of the keys that we like to bring up when someone asks us this question is that we all need to become more reflective of ourselves. We need to engage in active reflective practices. So this includes checking in with yourself regarding your biases and making sure you're checking in with the way that you're communicating to other people. So on the left side of the screen here, we have the basics. Everybody knows these: tone, volume, emphasis, silence, and body language. With one simple statement, "they said he did it," each of these can enact a different meaning or a different impact on that same sentence. So tone, is it a negative tone? Is it a positive tone? They said he did it. Volume always implies a power structure. And so you want to really be careful that you're not overpowering the conversation when somebody's trying to explain their lived experience to you or their perspective. Emphasis, what you decide you want to emphasize in the statement. Well, they said he did it. It's a totally different meaning. Silence is a big one, especially in a lot of these difficult conversations that come with anti-racist work. The kind of natural human response is to listen, to respond. But in this work, we find often that listening to hear and to actually actively listen is typically a skill that takes some work to get used to, but is very important and essential in this work. And lastly, body language. You want to make sure that your body is into the conversation that you're having. If you appear closed off, that could really impact the amount of conversation and communication you have with someone else. So our responsibility as healthcare professionals and with patients and families is to listen attentively while being aware of how we are presenting with our emotions. And like I said, with these difficult conversations, processing your emotions needs to be a step that you think about. And so empathy is the key here. It is so important to take yourself out of your own shoes and try on someone's shoes for a day. You might never have imagined what somebody else goes through on a daily basis, what they think about, if they feel safe. And so that's something that's very important. And so with that, we can't let these emotions dictate a conversation, because if we do that in certain circumstances, you could really hinder getting to the meat of the conversation. So on the right side of the screen is just a little kind of mantra that we like to remember when we're having these conversations, just to be able to process your own emotions inside so that you can then put forth the actual information that you want to put forth. So reiterate. You just want to kind of repeat what you heard, what you gained from the other person talking to you. Contemplate. Take a good, 5-10 seconds and really think and process about what you heard, what they said. Respire. So breathe, take a moment, because when these conversations happen, it's easy for emotions to bubble up to the surface. So just take a moment, acknowledge them, right? Actively reflect on them, but, bring it back to what you actually want to communicate. And that's kind of a mantra that we like to share with people when they ask us, well, how do you start to have these difficult conversations? Again, it's all about these active, reflective processes. So now I will pass it off to Pam, who is going to talk a little bit about a different model called PAUSE and how we're using that here in the medical center.
Tyra, and I'll be building a little bit off of Tyra's discussion on communication and talk about how we recognize bias and how we address bias using the PAUSE model to create a culture of inclusion. And as nurses, we are guided by a moral compass to treat patients with dignity and respect. And that involves recognizing the entire patient to give the best care, their culture, their language, their beliefs. And at Tufts Medical Center and Tufts Children's Hospital, nurses are committed to creating that environment where we can heal and comfort and learn. But we're not alone. And as one coworker who's not a nurse pointed out to me, that we all work at Tufts to help people. So in healthcare, our best practice is guided by science. And the research literature recognizes the existence of racial disparities, inequities in care that exist across the life spectrum. But if implicit bias is unconscious, then how do we recognize it? And we have to actively pause. So PAUSE is the model we use here at Tufts to recognize and address bias. And recently, we, as a group, were able to speak with an employee at Tufts who shared barriers that he experiences as a Black man, and that we were actively able to pause and listen and and question and ask more questions and listen more. And that one conversation was just so impactful for everyone in the room to understand a different perspective, and that we were able to hear the experiences that he has, and kind of see the world, his day through his eyes. And we asked, what does he want from this conversation? And his response was that he just wanted respect. And so for me, that was truly eye-opening, because everyone deserves mutual respect and to have their voices heard. And the culture here at Tufts Medical Center and Tufts Children's Hospital is that we respect our patients and our coworkers as individuals. So when we hear that one individual is asking for respect, then we all need to actively pause. And with that, we need to review the pause model so that we can recognize and then address bias. So the P is let's pay attention. So neuroscience tells us that implicit bias exists as the brain's tendency to kind of simplify the world and make mental shortcuts, and that the brain has evolved to have bias. So then we need to pay attention to what we think and what we do, and pay attention to what we see and what we hear. We have to have self-awareness of what we think and do to help us regulate our reactions to emotions. Take a mindful moment, take a deep breath to interrupt the emotional brain and allow that thinking brain to take over. That mindful moment, I need to check in right now. Where is my mind? Where's my attention right now? And I need to do this so that I can be present for my patients and my coworkers. We need to reflect afterwards, like what we think and do after the moment has passed, so that we can learn and possibly, act differently. Do we realize that this might be happening during a stressful moment? How can I now regulate that behavior in the future? And we need to recognize how we respond so that we can then interrupt that pattern of response. And it's okay to ask for help, because we also need social awareness, what we see and what we hear, in order to be able to influence positive change. So constructive feedback from our peers and from nursing leadership, it's so important for us because we are all human. And what I've heard my colleagues on this panel tell me is that, they might say to someone, we're not calling you out, we're calling you into this conversation, calling you into the behavior. Are you aware of the impact that whatever the behavior, that conversation, that tone, the words you use had on a patient or on a coworker? And nurses, we're leaders in healthcare, and we give and receive feedback so that our peers know our expectations as a medical center, as a community, as a profession of nursing. And we share these high expectations with each other because we truly believe and know that our colleagues and ourselves can all reach these expectations and do the best for patient care. So after we pay attention, we need to A, acknowledge your assumptions. Allow ourselves to get uncomfortable with what we may find. Implicit bias is unconscious and forms through messages that we have received throughout our life. So we may become a little defensive and deny that any bias exists. And that's our brain that wants to protect us, right? It has that fight, flight, and it wants to shut down any unpleasant thoughts right away. Let ourselves be vulnerable though and explore what we might find there. You may ask, did I scan the room and I didn't see the doctor? Or did I scan the room and I saw a Black man and assumed he's not the doctor? Is that racial bias? The brain wants to shut that thought down right away, right? I'm not racist. But is it possible that I didn't see the doctor? Is it possible that that was racial bias and that we were quickly scanning the room? So we need to allow ourselves to be vulnerable and reflect on that, because even though it's uncomfortable, we need to acknowledge the possibility of racial bias, because nurses are trusted and we have a responsibility for our patients. We then need to go on to understand your perspective. Our journey and experiences shape who we are and how we view the world, but perspective is individual. So I can also gain more perspective from others. I can seek different perspectives, be curious, ask questions. Help me understand what you experienced. What do you want to see changed? I was very humbled having the opportunity to talk with an employee who does not look like me and listen to his experiences. One conversation led to another conversation with the DEI members on this panel, then another with nursing leaders, and then each leader continued that conversation onto their own units. So we did gain small but different perspective. And that one conversation was just a flashlight shining into the dark. So we need to have more conversations so that we can have a broader perspective. After we have a broader perspective, we can examine your options and make a decision. So nursing practice, we talked about, is guided by the Code of Ethics, and many professional organizations, like the Organization of Nurse Leaders, are sharing position statements to support the culture of diversity, equity, and inclusion, and asking nurses to pledge to be champions, to actively listen and learn and promote the practice of self-assessment so that we can do better. Ask yourself, how can we be allies to undo racial bias? Let's pledge to continue being curious and keep the conversations going. We are inspired hearing about these conversations about racial bias here at Tufts, and encourage all nurses to use the pause model so that we can both recognize and address bias. Pause and reflect and talk about it, even if it's uncomfortable, because undoing racial bias is important. And remember that coworker who was not in nursing and told me that we all work at Tufts to help people. So nurses at Tufts are committed to changing culture, to undo bias, so that we can continue to learn and to grow and be better nurses tomorrow than we were today, both for our patients and their families and for each other.
Yeah, one thing to emphasize in the model is that, to the point, is that we're here to care for people, and also we can use the model to use inclusion, and in many cases with nursing leadership, they always look for ways to engage other members of the care team that will have a perspective, and the pause model is a very helpful tool to also do that.
Perfect. Those are great points. Thank you, Pam, and thank you, Rosa, for bringing those up. So still thinking about this Tufts board, what can we do when striving for this anti-racist culture in healthcare? At the start of creating this DEI nursing work group back in June, I don't think that we as a group exactly knew where we wanted to take this. I don't think we knew exactly what we wanted to accomplish. We just knew that something needed to be done. Something needed to be said. We needed to do something to help make the hospital and this world a safer place for our non-white brothers and sisters. So months later, about in December, I came up on an article, and in that article, it laid out some kind of key components for anti-racist clinical care. And so I shared this with the group, and this led us to kind of hone in on these 5 quote unquote steps. And we believe that these would be kind of the most important broadly in Tufts Medical Center and Tufts Children's Hospital journey to an anti-racist nursing culture. So on the screen are those 5 steps that we thought to be the most important as a group. So flashback to June, when the nursing DEI work group was tasked to host a nursing town hall throughout the hospital. Without thinking, this nursing work group immediately set out the task of steps 1 and 2. With this first forum, we went through a synopsis of American medicine and the institutionalized racism in the industry since the era of slavery, all while connecting it to present day and the different struggles that non-white people have to go through to even end up in these positions. The feedback we received from that first open forum was strong and abundant. For some, it further solidified the behaviors and language that they had bear witness to and made them feel as though they weren't alone. And for most, it opened their eyes and minds to the reality of the system that they may or may not have been aiding and perpetuating. So we had nurses with decades of experience on the job tell us just how enlightened as well as equally kind of ashamed of the system they were, and how they were grateful that, you know, this nursing work group was vulnerable and willing to take on the challenge of changing the system with pledges of their support along the way. So we appreciate that from members of our own nursing community. As we continue our nursing town hall forums within our institution, we are now moving more towards steps 3 and 4. So as Pam so eloquently stated, we are now hoping to use the pause model and other self-awareness tactics, such as the mindful moments, to help guide our staff into this new vision for nursing here at the medical center. Our goal as a nursing work group in DEI is really to arm our staff with the tools needed to advocate for their patients, advocate for each other, and for other staff members in the hospital when they see or hear behaviors that do not coincide with our vision. It is our hope that with the proper tools and guidance, we will empower all members of our staff to be able to have these difficult conversations, address their biases in order to avoid, unconsciously acting on them, and to make this hospital campus a safer one for everyone who walks in. With the scope of nursing being so vast, we also recognize that frontline clinical nurses such as ourselves cannot do it alone. We have partnered and included our nursing leaders and managers into these conversations as well, and trusting these leaders of their individual units and departments around the hospital to model these behaviors to the nurses and staff in their respective areas. We also partnered with Dr. Rosa Colon-Calaco, the Welfare System Chief of Diversity, Equity, and Inclusion. And the key here is to enact this anti-racist culture at all levels, individual, institutional, and policy. And the last step, healthcare systems need to actively invest in the people and the communities they serve, the people and the communities that have been mistreated in this healthcare system. You think of healthcare in general, not all patients get the same exact treatment, regardless if it's the same exact diagnosis. Dependent on severity, one patient might need more or increased therapies compared to another. That is equity. And healthcare systems need to practice that same principle of equity into the people and communities that the system has deemed inferior for so long. Ultimately, the steps on the slide are listed numbers 1 through 5. But as I stated earlier, this journey is not linear. It's not easy. These steps are not consecutive. We acknowledge that all these steps need to happen simultaneously on a continuum. Cynthia, Mary, and I, along with members and allies of our nursing work group, understand that there isn't one true final destination on this journey. Rather, we want to find a path leading us to the right direction. We as nurses and participants in the healthcare system know that learning should be never ending. Our hope here is that we create a culture that is open-minded, eager, and willing to learn about what other people face in their daily lives, and ultimately willing to make the gap of inequities smaller and smaller.
So the
Tyra,
steps, I'm sorry.
Sorry, Tyra, excuse me, I just want to I love your humbleness and your cues on sensitivity and inclusion, but we have a question in the Q&A box, and I'd like to see if it could be addressed. And the question is that we have a high number of patients of Asian descent at Tufts. And the question is, much of the DEI and bias work, the belief is it doesn't address Asian American experiences. And so they're asking, how is Tufts approaching this? Rosa, do you think that this might be an opportunity for you to address some of the work that's being done?
Yes, thank you, Judy. One of the things that we're doing, I think, Tara, you mentioned it very correctly. I think we need to have a culture of humility to allow our communities to really teach us. So one of the things that we've been doing is strengthening our community partnership through our health equity work, including during the pandemic. We have a lot of challenges, and the Asian community felt that, okay, so you have the answer, maybe we do have the answer. So we will have an issue with the pandemic. We partnered with them, and we really were able to close the gap of disparities of vaccination rate. And the number one key was to listen. When people are admitted at Tufts, we have the interpreter services that not only provide interpreter services, also provide cultural needs, and they also assess their needs, and we do according to people's needs. So we need to have in mind, for me, is to listen to learn. Sometimes we tend to judge how much we know, and that's one of the key things that is one of our principles, not only with the Asian community, but to all our multicultural patients. Okay.
All right, so I'll start it back up. So just to follow what Tyra was saying, the steps that we have implemented at the medical center are really a simple guideline to use for not only ourselves, but our coworkers, our family, our friends. And by using these steps, we're able to grow in our own journeys towards living with an anti-racist mindset. So as an ally, personally, I've realized the importance of really understanding the history of racism in our country and acknowledging those around me who have these lived experiences with racism. As a white woman who doesn't have these experiences, it sometimes can be easy to forget what non-white populations have to go through on a daily basis. So I truly stand behind this model, and I believe that these are steps we can all use to achieve an anti-racist mindset. So moving forward, to build off what Tyra was saying, what is nursing doing and what are we doing at a system level? Although there's still a lot of work to be done, we wanted to highlight some changes we've made. So as nurses, it's in our makeup to advocate. With this topic being of such importance to healthcare and society, we as nurses have been called to spread awareness. Utilizing the town hall series that Tyra just mentioned, we hope to create a dialogue surrounding racism and promote education within hospital employees. In addition, we've established the DEI committee designed to address and mitigate problems arising in the medical center having to do with race. On a system level, there have been upgrades among our policies and protocols. By adapting the attitude that Tufts is an inclusive environment, we have changed our obstetrics guiding tools for pregnant mothers to reflect assessments based on individuals as opposed to a generic risk assessment checklist. The previous checklists do not accurately reflect the important differences these women have that may predispose them to more severe complications post admission to the hospital. Another step we have taken at the medical center is that we have adapted our consent forms to reflect the concept of bidirectional acknowledgement and mutual respect. This is among providers across the care continuum and patients. By signing the consent, the patient acknowledges that mutual respect is necessary for optimum health outcomes. With these changes in mind, future steps for Tufts might involve more external hires from the community due to, as we have mentioned, extensive barriers in our society for its non-white members. We miss out on a lot of potential prospects. One way we can address this problem is by setting up an outreach program in which eager future health care professionals have the opportunity to shadow or work at the medical center, giving them the real life experience needed to make connections and build relationships within the healthcare field for their future employment endeavors. It may also be beneficial to take a look at our current reporting systems. So we do have a way to report safety events, but no way to review or document how racial incidences may or may not affect patient outcomes. So to conclude this presentation, we obviously have taken a lot of the necessary first steps at the medical center, but there really is still a lot to be done.
Mary, I'd like to ask you, are you aware of how you might use, as a nursing collegial group, how we might use, I should say, nursing surveys to really, if something comes back with this message of I did not feel included, or, I felt a sense of racism, how do we approach that from the local? And then Rosa, maybe you can tell us from the system level some of the key works that are happening in there.
Yeah, absolutely. So I would say if this happens in the moment, we can utilize that pause model and really slow down in this situation, maybe ask some leading questions such as, I just want to clarify what you're saying here. Did you mean to say this like this? That way we don't put up a defensive barrier to neutralize any sort of conflict that may arise. I would also say this is a huge area of improvement for us. The DEI committee is starting up, and this is a way for us to talk through conflicts that might happen. And with Rosa's guidance, I think this is a very real situation that could happen. So I'll let Rosa, you can take over.
Yeah. Thank you. So one of the things that we're doing is leveraging best practice in this area. So we are very diligently listening to people's feedback through the patient experience office, and we're capturing that information. However, we're trying to make better is to bring the group together, as Marty mentioned, to use the pause model to see how can we remediate the situation. In some cases, there may be some misunderstanding with the language differences. Sometimes the interpreter only come once in the process. So one of the things that we're trying to do better is to bring the interpreters maybe throughout maybe in rounding, in visiting the patients, to ask them how is the experience, how things are going, what else can we do within your culture, and also documenting this more on an ongoing basis so we can use those case studies to learn. So more to come on that, but we're very committed to continue improving that process.
Rosa, I have a question. One of the attendees is asking, if you could possibly give some examples, and maybe the nurses can as well, around what does it look like in practice to assess cultural needs? What does that look like?
Yeah, I'm sure that's one of my favorite topics. And right now we are designing Epic to implement Epic, and we are designing Epic to be culturally competent, so we can use systemic ways for the system to remind us. So when we talk about cultural differences, we talk about from your, it's not only language, it can be your values, the country that you're from. What about LGBTQ? So sometimes we make mistake about assuming that you have a spouse because you're a woman. So, so also dietary, religion, including, how even your dressing gown, sometimes people feel uncomfortable if we have, I use like I'll cover my body and suddenly I give you this gown. So one of the things that I have done in other health system, we even change that gown. So one of the things is that adding those questions when the nurses do the nursing assessment, and through Epic, we're going to allow them to even do that automatically. So they can go to the My Chart and My Bedside section and tell us. And right now we're even exploring to allow the patient to dictate in their phone, in their language, and then translate it right away into English to the receiver of the message. So we're doing our best to leverage technology to do that as well.
And nurses, what can we do from that perspective, from a perspective of looking at cultural needs, assessing those? How do we do that, not only at the point of care, but throughout the continuum of the actual care we provide from inpatient to outpatient and back into the inpatient setting?
Yeah, I totally agree with what Rosa said. And it actually is in our nursing assessment to kind of ask about those religious beliefs, those cultural associations, things of that nature. Something I like to do in pediatrics, because a lot of the time you're dealing with not only the patient, but family and extended family. And so asking them, like, what is your goal of care for today? Like, if you had to pick something or a few things, what is a priority to you? Because a lot of the times that is culturally or value or morally based. Another thing is interpreters are a big thing. So making sure that even overnight when things are slow and there's not as many people here, we have video interpreters, phone interpreters to make sure that the message that somebody is trying to get across in a different language or what have it gets across properly to us as the care team. And so I think just, constantly checking in with your patients and their families and making sure that they feel heard and trying your hardest to accommodate, what would make them feel more comfortable, more safe, more, more something that would help them better with their health. And so I really think it as much as it is a communication-based system to attack anti-racism, it's also a communication-based system to work with your patients and making sure you're respecting and acknowledging their culture and their values as well.
Cynthia, you have a great endeavor in your future, getting your PhD and really working hard towards making a difference in this topic. I have a question for you. How best can we address these biases or racism in education and training? And how do we provide our advocacy and our actual transformational leadership to address the stereotyping that goes along with inequalities in education and training as health providers of the future?
Well, I think we definitely need to start at the academic level, and this is not at the collegiate level, but this is like when I'm thinking back to times in middle school where I know that there are, people who look like me, who came from the same community as me, who were on par with me with education, could have those opportunities to go to great schools like Northeastern, go to great, just four-year colleges in general, and to be able to participate in these nursing programs for the 4 years that Mary, Tyra, and I did together. I think we need to not only include them, because I feel like it's very unsafe to include, people of color, non-white people, just for the sake of checking a box or just to say that we're promoting inclusivity without actually embodying it. And when we start there and bring in more people who are feeling safe and feeling included in an environment where nursing is to just provide the care to help people, that's all why we all became nurses. Starting there and then trying to foster a culture of unlearning behaviors, because I know that when, you know, Tyra and I started college together and finished college together, and I know that there are certain things that we had to unlearn. We learned in our own, you know, experiences as nurses that could really contribute to that bias. So there's things that you have to foster into the nursing curriculum to make sure people do unlearn. And then from the research side, now that, you know, I'm getting into that advanced stage of making sure that, you know, research is equitable, and community-based participatory research is really involving the community, uplifting the communities around us, rather than just, again, checking a box to make sure that we've done the work to help people who are non-white, or gotten that money to fund a project that surrounds minorities. We're making sure that we're understanding our communities and being guests inside those communities that we are conducting research with. I think what is also very important is that we debunk those myths of, you know, Black inferiority that shows itself in different forms. I think Black inferiority is not just, or inferiority of minorities or non-white groups is not just, you know, significant to Black people, but I think also, as a guest mentioned, Asian Americans and Latinx people, we understand that that inferiority is centered around a lot of cultures and been perpetuated by this racist medical theory. So really working to undo those biases in research is really going to be a step forward to making sure our evidence-based practice is based on the most current evidence, making sure we're not teaching or perpetuating the notion that, you know, Asian Americans present this way and Black people have expressions of pain in this certain manner and Jewish people have expressions of pain in this certain manner. I think we need to unlearn a lot of that on multiple levels so that we can understand and truly embody that anti-racist culture.
And just something to add from that, you know, as a white woman, I think it's important to, in the workplace, in society, to, if we do see these things happen, address them on the spot. Like Pam was mentioning, you know, instead of that call out behavior, we would call into a conversation. It really is important those who do have the knowledge and the background behind racism in our society, educate those around them. You know, we have a duty to do that. And as nurses, we want to advocate for our patients. And, you know, our patients don't all look the same and they have a lot of differences. And I think it's really important as an ally to address that with people who look similar to you.
I think there's also another question on the chat.
Yes, it talks about how, it says, how is the DEI group address resistance to anti-racism concepts like critical race theory and other misunderstood paradigms among colleagues in the institution? So maybe we can sort of, you know, take our model and kind of see how we kind of build upon that to address some of these issues.
Yeah, I think one of the things that I want to comment is that we all have our own stories. And when we think about the legacy, there is a legacy. This is very multi-layer. There is a legacy of our country. We think about Juneteenth happening last week, and yesterday we have our celebration. So then there is an individual experience that we have observed. When people have not observed some of this behavior, sometimes unconsciously we're in disbelief, you know, like this is not really happening. And I think the more we are brave enough to share stories about what we have seen and create an environment that people can come and tell our stories and say, you know, you said this to me and this is how I felt. Yeah. So let's talk about this. And normally when we do, we try to, we need to feel comfortable feeling uncomfortable. And sometimes those conversations take bravery, which was in our model. The bravery not only to call it out, a bravery to share the story.
What do we say about when we present the history of racism and the background behind that and some of the things that happened in the past? How do we acknowledge that there may have been cooperation or partnership when in fact, you know, it was it was not as optional? How do we address, like, one of the things around the syphilis studies where some people believe that there was cooperation in based on the readings and the history of what occurred? How do we address that moving forward rather than making it conflicting, but rather acknowledging that history is history? And how do we build upon that for a better place? Yeah,
Right.
maybe.
I think, sorry, Judy. I think that, you know, I feel with history, you could play the blame game forever. Everybody is going to have a different, you know, kind of subcontext on what happened in history. You know, that's kind of the case when things are, you know, one side, you know, versus another side. I think what we try and focus on in this nursing work group, especially around this issue, is just the people it happened to. And so negate whether it was, you know, whether people think it was the government, whether people think there was, you know, collaboration. What happened to the people was wrong. And so that's kind of the big focal point for us. What happened was wrong. It shouldn't have happened. We don't want it to be repeated. Obviously, that's a whole different time zone, but that's where we kind of go in this anti-racist talk. So, you know, not so much about harping on, you know, who funded, who did this, but the action of itself is wrong. And if we think about today's society and what that would look like in today, like it's just, we just don't want to see that happen anymore. We don't want people to be subject to things just because of the color of their skin or their beliefs or you name it. And so I think that taking out that kind of, you know, concept in the background and just really making sure you're focusing on the people that were affected, I think is really important.
Well, I'd like to, we're at time, and I really would like to thank you as nurses of Tufts Medical Center and Tufts Children's Hospital, Rosa as our representative and Chief Diversity Officer, really help us, you know, in helping us really leverage this opportunity for these nurses as well. Kate Braun and the Boston Globe. I think that, you know, what we see here today is an instrument of caring, comforting, and healing, and that we are some strong advocates to do better. And I applaud you for being courageous and for leading forward and for really thinking about that, building knowledge, skills, attributes around this competence, sensitivity, humility is a team spirit. It is not solely by one or two people. And we stand by you. Thank you.
Thank you. And it's a journey, a never-ending journey to get better for humanity. So
I agree. Thank you, ladies. Very
Thank
nice
you, ladies.
presentation.
Thank you.